You know, it reminds me of something I was going to mention a little later. I'll mention it now. But this paper just published in the Journal of Consulting and Clinical Psychology by John Weiss. I think it's probably, if we pay attention to it, maybe the most important paper in 20 years in child mental health. It's profound in its implications. What he showed was that you can talk with a client, patient, kid, parent, and you can ask them to identify their 3 top problems. They put it on a scale, every problem. 1 to 10. 10 is bad, 1 is great, okay? And when they just track that problem, first of all, it's not usually on your DSM, and it's not usually on your, half of them aren't on your CBCLs or whatever, but they map wonderfully well, they're reliable, and they track progress well, and they make such great sense to the family and to the clinician. That if we were to do that, whether it be on a, I'm reminded, you know, it would be very interesting. When might a kid have a self-rating responsibility? He's actually rating his mood. It's up there or his behavior. And he's actually kind of rating himself and then brought it into the community room to get other feedback on his own self-rating. I mean, you know, this issue of assessment is so central to appropriate use of medicine. So it's not just diagnosis, but it's all that other stuff that so many of you are pointing out.
And that self-assessment and self-view is so crucial for kids and adults.
And you know, if we are doing little checklists and the kid isn't involved, we're missing an incredible opportunity. It's a way to communicate with a child and a parent and a family. It's a way of teaching and exchanging. Well, we do have a case. So Todd was coming today, and I know that he's had a hard time. I don't want to go to the quiet room, and you can't make me. Yeah, but he dissed me, and you can't say that. Just pisses me.
Todd, you're throwing chairs. What's going on?
I don't even want to talk about it. He shoved me, and then he said something about my sister. It's disgusting. It's just.
Somebody pushed you?
He pushed me, and then he.
Upset you?
He did. He pushed me, and I hit my head against the wall. And then he said he didn't even know my sister. He just saw her in the unit the other day, and jeez.
You're really upset about that. Todd.
Oh.
Do you want to take a walk, talk about it?
No, I don't want to walk. I don't want to talk. Where is he? I'm gonna go get him.
Todd.
Okay. Okay. I don't know where the texts were, but.
I was just trying to decide if I needed to do something. Should I block the door?
Don't know where the texts were. Okay, so let's play it again. Watch what Lisa did. Think about what Lisa did. And now Lisa's going to come in with not quite the same clinical skill. She didn't make me madder. You saw me begin to calm, and I thought about it, and I don't want to give up my anger. Okay, so, but I felt a little calmer when she started, you want to talk about it. Well, that was interesting. Most people, throw me into the hold, So let's do that again. And Lisa, if you need any psych texts, there's Bob over there. I don't want to. I'm going to get him. That pisses me off. He can't say that to me.
You know the rules on the unit. There's no
You can't tell me. You get out of here.
You're going to have to go on.
You get out of here. You can't tell me what to do.
I need a tech on the unit.
I'm going to get you. Cut before this gets any further out of control. Okay, well. So this is something we see all the time, sure, in the inpatient units. And so the problem is, think about the two scenarios, and kind of given that situation. Now, I would bet you see this range on your own units. Thoughts? What are the issues? What are the problems? If you were to intervene, not acutely, but if you were to intervene, because you know what's going to happen. They're going to ask you to intervene with a script. That's where you're going to be asked to intervene. And, you know, I wasn't in perfect control when Lisa was different, but it was closer, and she might have had me. Okay, so let's do something, because obviously this kind of problem is complex, and obviously there might be some things you could do in the heat of the moment, learning, and maybe some things next day, but it's for certain, if I don't have a way to really openly and honestly discuss with everybody what went wrong and what went right, and really have a real open discussion that's a bad kid. If I got that going, it won't work. I can't. And I was struck when I came to Mayo. Now, I think we have a pretty good unit, but I said pretty good unit. Because I would come into units and I'd find some very angry patients, and I love taking calls because I find out a lot of interesting stuff. It's a great way to problem solve and to do quality control. And I would see sometimes after a very unhappy parent, and then one of my docs would tell me, oh, I didn't want to take sides. I saw nursing staff over here and over here. And I thought, take sides? There's only one side. Not sides. And we're here to treat patients. And this whole issue of win-lose control, it's always lurking there. And is there a climate where someone can really say, how do we understand so that won't happen again? That's an interesting thing. Now, we're going to give one more role play. And this role play is a little different because not only do they have Lisa's great skills, but they also planned ahead of time because they thought about this kid and his vulnerabilities and even discussed with him how they involved the kid when he had his stuff. So that it's kind of a part, he's actively involved in working on his temper problems. He knows he's got terms for it, he's got words for it. He talks about his explosions. Yeah, I'm working on my explosions, doc, you know. So they took it one step further, added some of the cognitive behavioral, if you will, proactive, did problem solving before, and they always problem solve openly thereafter. So let's try it one more time. Okay. I'm getting exhausted. I cannot believe this stupid. I don't want to be here anymore. I've been here for so long, and the people are going to mistreat me, and I don't want to do it. He can't treat me that way. He made fun of my sister, and then he pushed me, and I hit my head against the wall, and I'm tired of being here. I'm never going to get off this level.
You're really at the top.
It's just.
Top.
Oh, what?
Let's talk about this. Remember we were practicing what to do when you're angry?
Oh, I can't do that now.
Let's try.
Oh.
Sit.
Oh, he said this. He was talking to my sister.
He was upset about talking to your sister.
And he pushed me. Do I have a bump here?
We'll take a look at it.
Oh,
Here, sit. Good.
Oh, he should be in timeout for doing that.
Yeah, you're really
Okay,
upset.
got it. Okay. Oh, boy, I'd hate to be a kid again. That would be bad. Okay, so energy consuming. Okay, so you can see actually there's a little, you start adding these things together. There's just a way to, but staff training, maybe only one at a time, a favorite nurse or someone else you can begin doing this with, or a rating scale. Develop a few people in a way I can begin to gently teach and take forward. My hero for psychiatric examinations is Columbo.
Yes.
He was such a master, subtle interviewing and being always a little bit Art Linkletter-like, curious, scratching his head and asking the most offensive questions. So, and just people telling, yeah, I think that's right. Playing that detective is a very critical role. What I want every table to do, if you had to pick a place to begin for staff training milieu, Think about staff, think about Todd, and think about Todd pharmacologically. Given what you kind of think, if I had to change medicine, what would you do pharmacologically? So that's your task. You had to pick a top choice for the staff, what you wanted to work on with Todd, and what you might do pharmacologically, and any additional assessments. Okay. So we had three tasks.
We need
Let's
few
take
more
a.
minutes.
Okay, I'll just go slow here. Okay, writers keep on working, and let's see what the top one that most people said for the milieu. So notice over here, staff training milieu, crisis intervention to crisis prevention.
Change crisis intervention.
Yes, that's very interesting. Who can someone speak to that?
We just made it up.
I love it. It's really cool. But that's exactly what the principle is.
We have no idea what we're talking about, but
What
that'll
is
work.
your behavioral intervention program? We're using CPI,
Right, we're using a
NAPI,
bunch of
TCM, and all these
Or
things.
TCI.
We wouldn't have to use that part of it if we were constantly doing prevention.
Okay, so now if I were tracking those little instances like this per shift, I might even say, you know, this shift might really benefit. Or the shifts have a little target going. They're all kind of racing to see who can do the best. Morning, afternoon, evening shift, night shift. They're all being tracked and they're looking at their little tracking chart. Day of the week. Day of the week. The nursing, the nurses are all kind of wanting to have the best. It's just tracked, Wouldn't that be interesting? And then I might even know where I might want to, help shift that climate. Let's, what do you got up here? Is it the same point? Manage crisis, use distraction.
Collaborative processing, problem solving.
De-escalate, triggers. Okay, yeah, so I'm just looking. We're just doing the top one. So de-escalate, distraction, examine triggers, and problem solving. So it's a proactive approach, right? All right, let's see up here. Okay, now this is, speak to that. This is a very different thing. You're getting into some everybody? Okay, so tell us about this. This is very interesting, this coming authoritarian stance.
We were talking about the second scenario, so that she shouldn't come in saying, you want staff to come in saying, you know what the rules are, you can't do that. But just, as far as staff education, that's not the best way to intervene. That you want to come in more and say, these kind of got out of order because we were trying to add things, but come in and label the emotion, like you look very angry, tell me what's going on, so you want to, come in first, try to connect with the kid, label the emotion, invite them to explain. If they can't explain what's going on, if you're going to give them directions, use simple language because his IQ is 88, and give him some directions that are calming. And then, so that, those are kind of sprinkled throughout that, and then, going through debriefing with the staff, going through with the staff, figuring out what's the kids' behaviors like in between these episodes, what happened, what do people think was going on, are there staff members whose style he works better with, that maybe we could learn something from.
Very lovely. This is beautiful, and they're all wonderful, but why couldn't every one of us do a little role play with staff at an in-service, just like we're doing here? And they have somebody who's really good. This isn't rocket science. And then we kind of maybe find the shift where it's needed a little bit more. Use some of that, demonstrate it, and have a few people try it. You try it. No, you try it. Good job. You try it. Yeah.
With the child.
How's that?
And with the child.
And with a child. Yeah, absolutely. And so we get one of the kids, hey, could you come in and have fun throwing a temper tantrum? Help teach us. Absolutely.